Mhm. Dear colleague.
As all we know that the CO2 angiography is non-allergic, non-nephrotoxic intravascular contrast material used for peripheral arterial imaging below the diaphragm and safe in patients with renal insufficiency or iodine allergy. The evolution in CO2 in vascular surgery started from 1982, and it was discovered accidentally by Hawkins that when he advertently inject gas inside the arteries and the celiac and its branches become to appear, and uh, fortunately this incident passed uneventfully. But after that, the CO2 went uh, severe development in uh, inventing the delivery systems and the techniques for the use. So what makes the CO2 different from the iodinated contrast materials? Let's review some physics. Because the density and the atomic weight, as all we know, the CO2 is a gas and it's less density, so it absorbs less X-ray. So appears in the background, it's clear, bright, and the on the dark background, while the contrast, the alternating contrast, become dark in the bright background, just like this image. The buoyancy of the CO2 that when we inject inside the artery, it actually doesn't mix with the blood, as this picture describes, like the iodinated contrast material. So if the CO2 displaced the blood, the vessel will be visualized. The buoyancy also is responsible for the vapor lock action that occurs when we inject inside the aorta when it's dilated or during the crossover. It may lead to locking the inferior mesenteric artery. So must be careful during the injections in these areas. The CO2 is readily soluble and dissolves in blood more than oxygen 20 times, and it carried through the lungs and eliminated in 60 seconds. Also, it has a low viscosity and can be administered at a high rate, even through the microcatheters and the interventional sheaths. And the last character is the compressibility of this gas because it is liable for compression. Care must be taken during the hand injections because the pressure can exceed its limits and lead to explosive shots. This explosive shots is responsible for vessel distension and plaque disruption. So based on these facts, CO2 injection must be done through a special automated injector, allowing for delivering the CO2 at lower pressure and higher flow rate. There is no upper limit for the amount of the gas injected, and it gives best results in the infrainguinal vessels, especially the SFA. And also it gives a better filling for the anterior collateral pathways. When we use the CO2 in various pathologies like task A, B, even D, it gives us a good results, especially for the collaterals and the distal runoff. And all the studies that concerning about the SFA give us a good quality images reaching up to 90%. So the side effects of the CO2, it was the pain during the injection and it leads to emotion artifacts. So it can be reduced by injecting a lidocaine, small amounts. It can lead to reduce the pain during the injection. Also, the low quality images that can be created when we decrease the frame rate. So you need to be increased the frame rate to 4 to 6 and give space between the bolus injections, 30 to 60 seconds to allow the CO2 to be eliminated. And fragmentation of the gas bubbles distal to stenosis. And this can be done to stack the images together to avoid the bubbling effect of the CO2. And let me finish with this case. It was done the last week. So 64-year-old man, hypertensive diabetic, chronic kidney disease, not on hemodialysis. It was presented with worsening claudication and lead to a tissue loss. And the duplex revealed that there's a total occlusion from the beginning of the SFA. When we started to inject from the crossover technique, we found this total occlusion and tried to go from the antegrade approach, and there is a perforation here. So we went from the retrograde approach, trying to find our way to the true lumen and ballooning. Then passing the wire from the antegrade approach, we successfully went from the antegrade approach and start using scoring balloons. And this is the image after the scoring balloon. Then we start to put a DCB in all the segment and the closure, the site of the retrograde puncture. And this is the final angiogram. Thank you.
So now it's a great pleasure to introduce my co-chairman of this morning, Tanya Guzman, speaking about device limitation in thin vessels.
Thank you for the introduction, and thank you for the invitation. It's my pleasure to be here today to talk about the device limitation in balloon vessels. We are moving from the